có hấp. Hello, good evening, everyone. I'm Dr. Shreyas Deshmukh. It's my pleasure to welcome you all on behalf of Merck to this virtual webinar on precision oncology in metastatic colorectal cancer and the role of biomarkers in metastatic colorectal cancer. As we all know, the treatment landscape of mCRC is changing quite rapidly, and biomarkers have an important role to play. So today's meeting will be focused on the biomarker-driven approach to managing metastatic colorectal cancer. And we have a stellar team, a stellar faculty here with us in this meeting to discuss and enlighten us as to the recent biomarker-driven approaches in metastatic colorectal cancer. I will just start the meeting with a brief introduction about Merck and some of our initiatives which we are launching, particularly for this metastatic colorectal cancer and the NGS-driven testing. Just allow me to share my screen. So, Khushi, can you just confirm if my screen is visible?
Yes, sir, it is visible.
Yes. So I'll just briefly introduce the initiatives which Merck is driving in the space of biomarker-driven metastatic colorectal cancer management. So we as Merck, as an organization, we are the world's oldest pharmaceutical global specialty innovator. It has been around 350 years now since this organization was founded, and our presence is in around 66 countries. We term ourselves as a global specialty innovator with our strong pipeline, particularly in oncology and rare oncology tumors. And currently, we have an innovative oncology portfolio, particularly cetuximab in the targeted therapy class, avelumab as part of our immunotherapy class, and tepotinib, which is our precision medicine or MET tyrosine kinase inhibitor. And we are extremely glad to launch the NGS testing for our patients, for metastatic colorectal cancer patients. This NGS testing will be accessible through our co-payment support program, which we feel that will benefit a larger population of patients with metastatic colorectal cancer. So very proud to launch the NGS testing for patients. And we will have multiple options to enable this biomarker-driven treatment. We do have the NGS tissue biopsy, which has the NCCN recommended 12-gene panel. We have the NGS liquid biopsy, which has the key 9-gene panel. We also have RT-PCR tissue biopsy, which has a 3-gene and a 2-gene panel. So this will present the physicians with options as well as the patients with options when it comes to managing metastatic colorectal cancer, particularly focusing on the biomarker-driven approach. And as Merck, we are committed to enable biomarker-driven treatment in all our patients with metastatic colorectal cancer. With this brief introduction, it is my pleasure and honor to welcome our chairperson for today's meeting, Dr. Shekhar Patil, sir. Sir needs no introduction. He is a stalwart in the field of medical oncology. Currently, the senior consultant in medical oncology at the HCG Cancer Center in Bengaluru. And he has a solid more than 3 decades of experience in managing patients, cancer patients, particularly in solid tumors, breast, GI, as well as lung cancers. With that brief intro, I would welcome Sir, Dr. Shekhar Patil, sir, and would request to please take the proceedings ahead and guide us through this session. Thank you, sir, and over to you.
Yeah, thank you, Dr. Shreyas. Thank you, Mark, for having given this opportunity to be a part of this precision oncology in metastatic colorectal cancer treatment update today evening. So, as we all know that metastatic colorectal cancer, the most important thing we should do once we diagnose the colorectal cancer, and that if it is a metastatic, is to look for all the biomarkers, because the treatment is mainly based on the biomarker driven thing. And once you have got the biomarkers, particularly the NRAS, KRAS, BRAF, HER2, and the MSI. These are all the very important markers to begin with. We should have update on the first day. Then after assessing the patient's condition on the age of the patient, the associated comorbidities, and the sidedness of the tumor, we take a decision about the line of treatment. And as we all know that if somebody has got a high microsatellite instability tumor, and even though metastatic disease, majority of people do very well with immunotherapy, either single or in combination. And similarly, if you have got a biomarker like KRAS, NRAS, BRAF, any of those markers positive or negative, we have got good targeted therapies available along with the backbone of chemotherapy. We are able to get good long-term survivals. Generally, only with chemotherapy, we used to see a median survival around a year or so. Now, with the availability of precision biomarkers and targeted therapies and immunotherapies, we are seeing a good chunk of people doing even at the metastatic disease for 3 to 4 years. So there is a lot of advances have occurred in the treatment of metastatic colorectal cancer, a better understanding, and the most important thing is we should uh, uh, understand, work up the patients properly and use all the treatment properly, first line, second line, and sequence them properly so that we should be able to get a better quality of life and a longer survival. So today we are all here to hear from our speaker, Dr. Nidhi. She will be giving a current treatment guidelines in metastatic colorectal cancer, and after that we'll have a good panel discussion and with moderation by Dr. Dattatreya, and a lot of good panelists they are there, so we'll have a good discussion about all the aspects of what the metastatic colorectal cancer. So once again, thank you, Mark, for the opportunity, and now I'll hand over to Dr. Nidhi Tandon. She will be speaking on current treatment guidelines in metastatic colorectal cancer. She is a senior medical oncologist at Bangalore. It is over to you, doctor.
Thank you, Shekhar sir.
Yeah.
Thank you, Mark, for this opportunity. I hope my slides are visible.
Yes, ma'am. Please go ahead.
Yes, ma'am.
So my topic for today is a closer look at the current treatment guidelines in metastatic CRC. So since July 2022, various guidelines have come for the treatment recommendation in metastatic colorectal cancer by ESMO, ASCO, and even Pan-Asian ESMO guidelines. So there are the following key areas which have been discussed. Of course, the commonest is the RAS wild type metastatic CRC, but then there are guidelines for MSI high tumors, BRAF V600E mutated tumors. What is the role of liquid biopsy and what is the role of emerging biomarkers? So we will one by one go through all these topics. The first is RAS wild type. As we all know, right-sided tumors behave a lot differently from left-sided tumors. So the RAS wild-type tumors have been divided into left-sided tumors and right-sided tumors. Among the left-sided tumors, we have guidelines established from the 2017 meta-analysis done by Arnold, which showed that for left-sided colon, there is no doubt but to use a CT doublet with an anti-EGFR. But for the right side, we have options of using either a VEGF inhibitor with a chemotherapy doublet or triplet, or if only tumor shrinkage is our objective, even anti-EGFR will be utilized. So the meta-analysis was composed of about 6 randomized controlled trials which looked at the use of chemotherapy along with anti-EGFR, and they were compared with either chemotherapy alone or chemotherapy along with bevacizumab. So the first was the three trials which looked at the combination of chemo plus anti-EGFR versus chemo alone were Crystal, Prime, and Taylor, which found an overall survival, progression-free survival, and overall response rate benefit with the addition of anti-EGFR. As compared to this, the three trials, FIRE3, CALGB, and Paradigm, showed the superiority of anti-EGFR along with chemotherapy as compared to bevacizumab along with chemotherapy in left-sided tumor. What was surprising to note here was that there was an overall survival and overall response rate benefit. However, there was not much of a progression free survival benefit. And this led to the hypothesis that either the anti EGFR has such a good tumor shrinkage that we can achieve a curative intent metastatictomy in these patients so that we are getting a longer survival benefit which comes after a delayed point of time, or patients who receive EGFR inhibitors first have a better response to second line therapies. So these were the three trials, FIRE3, CALGB, and Paradigm. FIRE3 used FOLFIRI with Erbitux versus FOLFIRI with bevacizumab. CALGB, FOLFOX or FOLFIRI with Erbitux versus bevacizumab. And Paradigm looked at FOLFOX plus panitumumab versus FOLFOX plus bevacizumab. As we can see, in all these three, we had an increase in overall survival and an increase in overall response rate. However, there was not much difference in the progression-free survivals as we just discussed. Among cetuximab and panitumumab, there has been no head-to-head comparison, but if we compare the curves of FIRE3 or CALGB with Paradigm, we find that among FIRE3 and CALGB, the curves cross over at 6 months only, whereas in Paradigm, the curves cross over at around 28 months. Now, this may be because either panitumumab has a higher rate of side effects which lead to early dropouts, or the patient had early mortality which lead to the overall survival benefit coming only after 28 months. What happens after the induction with the EGFR or VEGF-based inhibitor? So the guidelines recommend that once the patient has achieved a response, we need to continue the maintenance with chemo plus minus the targeted therapy, which could be an EGFR inhibitor or a VEGF inhibitor, till the patient has a progression or till the patient has a toxicity. So, what maintenance do we use? Do we use a doublet chemo with anti-EGFR? Do we use a single chemo with EGFR? We use only chemo, or do we use only EGFR? So here again, this was a systematic review and meta-analysis where all these combinations were tried, and they found that if we look at the OS, either doublet chemo with anti-EGFR or only 5FU with anti-EGFR or only anti-EGFR yielded similar results. For PFS, 5FU plus anti-EGFR gave better results. So for most patients who have a good toxicity, who had a good safety profile, we would like to continue 5FU with anti-EGFR or capecitabine with anti-EGFR, but most of the patient want a chemo break, and we end up using anti-EGFR monotherapy only. Coming to the next second line therapy, what after cetuximab? So there is again no head-to-head comparison, but in Fire 3 and CalGB, we looked at cetuximab as first line, followed by bevacizumab as second line, which gave an overall survival of around 40 months, versus in other studies, bevacizumab was used first and cetuximab or panitumumab as second line, which gave an overall survival benefit of around 30 months. So maybe the first line treatment with anti-EGFR is a fair option. What after second line? Is re-challenge with cetuximab an option? So ESMO guidelines mention yes that cetuximab could be could re-challenge with cetuximab. So we have TAS 102 is trifluridine piperacil. So either trifluridine piperacil or regorafenib, or a combination with bevacizumab, but irinotecan cetuximab or single agent cetuximab could also be used. And this is because when the patient is given first line anti-EGFR therapy and the patient progresses, the resistance is predominantly driven by acquired RAS and EGFR ectodomain clones. But when we give a anti-EGFR pre-interval to the patient, the tumor regains the sensitivity to um, because the RAS EGFR mutated alleles decline, and hence these patients can be re-challenged with an anti-EGFR agent in the third line on progression. Coming to the right-sided tumors, whether it is ASCO guidelines or ESMO guidelines or Pan-Asian guidelines, we all know that right-sided tumors will behave worse as compared to left-sided tumors, whatever we do. But in such patient, anti-VEGF agent bevacizumab will be considered preferable to anti-EGFR, especially in terms of overall survival and progression-free survival. But is there a subgroup among this subset of highly aggressive malignancy in which anti-EGFR could be used? Probably yes, and that is a subgroup where we want a higher response rate for conversion therapy, especially in oligometastatic kind of disease where we are looking with a curative intent metastatectomy. However, most of us medical oncologists are still more comfortable in using bevacizumab over cetuximab in this population. This data of using cetuximab for achieving a better tumor shrinkage comes from some retrospective analysis of looking at overall response rates in Crystal trial, Fire 3 and CalGB studies, where cetuximab was paired, but it crossed unity, so how much significant it was is difficult to be ascertained. What is important to note, however, was the early tumor shrinkage. So the early tumor shrinkage was achieved in about 57% of the patient who had Erbitux with FOLFIRI, as compared to 41% in patient who had bevacizumab with FOLFIRI. So patients who are on borderline for liver dysfunction, or having a high bulk of metastatic disease are the patient in which we can still consider Erbitux. What about the other biomarkers? So the patient who are RAS mutated, we prefer VEGF inhibitors, bevacizumab with either a chemo doublet or a chemo triplet till the time there is progression. Among patients who are BRAF mutated, cetuximab Folfox along with cetuximab and encorafenib is preferred till there is progression. And of course, in MSI high tumors, either ipi-nivo or pembrolizumab is utilized based on keynote and checkmate data. For second line therapies among these patients, if the tumor is RAS wild type and anti-EGFR naive, then in left colon after FOLFOX, FOLFIRI or single agent irinotecan with cetuximab or panitumumab, in right-sided colon, chemotherapy with VEGF inhibitors. The BRAF mutated tumors would respond to cetuximab and sorafenib, the MSI high tumor to ipi-nivo or pembro, and the KRAS mutated tumors may be offered cetuximab or panitumumab with sotorasib. What about the tissue versus liquid biopsy? So traditionally, we have been using tissue biopsy to detect all the tumor mutations at baseline, but it becomes challenging when the patient relapses. So where can we use liquid biopsy? So when the tissue testing is not feasible or when quick therapeutic decisions are required, especially in patients in whom we are considering a re-challenge with anti-EGFR molecule and we just want to find the RAS mutated status at relapse, these are the patients in which liquid biopsies could be utilized. Summarizing, updated guidelines recommend tailoring first-line treatment approach according to tumor sidedness, right versus left in RAS wild-type metastatic CR colorectal cancers. NBEGFR with chemotherapy, whether FOLFOX or FOLFIRI, is the only option in left-sided RAS wild-type metastatic CRC, where first-line use of anti-EGFR has given an overall survival of approximately 40 months. Once started, it should be continued in the maintenance setting until the patient progresses or has severe toxicity. In right-sided RAS wild-type metastatic CRC, our most common choice of treatment is anti-VEGF, but in these patients, if a cytoreduction or an early tumor shrinkage is the objective, anti-EGFR molecule could still be utilized. Thank you.
Thank you, Dr. Nidhi, for a nice coverage on the guidelines in metastatic colorectal cancers. So we will take all the questions in the panel discussion. Now I'll invite Dr. Dattatreya, a senior medical oncologist from Hyderabad, and he will be moderating this session on integrating the strategies in the management of metastatic colorectal cancer, and it is a biomarker based selection. And it is over to you, Dr. Dattatreya, and you can introduce the panelists also.
Thank you so much, sir.
Thanks.
Thank you so much and welcome everyone to this webinar, and which is focusing mainly on the biomarkers and trying to see how biomarker based selections can be an integration to strategize the treatment in the management of metastatic CRC. And so we have Dr. Nikhil from Hyderabad Apollo Hospitals as the panelist, and Dr. Anup from Trivandrum, Dr. Anant Pai from Manipal, Dr. Vamsi Krishna Reddy from Hyderabad, and Dr. Vaishnavi Joshi from Bangalore. So these are the 5 panelists today who will navigate this journey of understanding how biomarker-based selection has evolved in the management of metastatic CRC. Next slide, please. So next, please. So the previous speaker, Nidhi Madam, was able to give a clear picture about how all these guidelines and recommendations, the data behind that. And if you look at the NCCN guidelines, whether it's the 2nd version or the 4th version in this year, when it's suspected or proven metastatic adenocarcinoma, molecular testing, they talk about RAS, RAF, RAS, BRAF, HER2 amplifications, MMR, MSI status if not done previously, and also talk about integrating the use of a complete genome profiling like POL D1, RET, and TRK, so that we'll be able to identify such rare and actionable mutations also. Next slide. And so a host of targetable pathways come up in colon cancer and rectal cancer. And to each of these target pathways, we have treatments which have shown their impact. Some of them are tumor agnostic therapies also. So with that, are all my panelists there? Nikhil, Anup sir, Anant Pai sir, Vamsi Krishna and Vaishnavi madam?
Yes, sir.
Yeah. Thank you. So let's start with Nikhil sir. Do you think, next please, any other biomarker that needs to be tested in the first line? Because I did make a note about KRAS, NRAS, HRAS, PRAF, HER2, and then tissue versus liquid testing. Your recommendation when and which setting, and then what type of testing you would integrate in your clinical practice? Is it just IHC or NGS? If so, just DNA based or DNA and RNA based, and what about fish?
Okay, this is something which we have been doing over a period of time, and I'm sure when we started our career and when initially we started writing cetuximab, we were happy to do only KRAS, and from those era we have evolved for more and more understanding about biomarkers. So the list what just now the NCCN has recommended is something what I would do. At least the first part of it, surely I would do. The broader NGS panel, I would request for most of the patients, especially those who are keen. And there are times when we have challenges for our patients who may not have all the resources, and then especially for therapeutic decisions, which we may or may not do certain panels, certain, I would say, biomarkers, like let's say NTRK immediately, but in the scheme of the things, they would be done. I would prefer doing a tissue biopsy in all patients in the initial lines. Liquid biopsy, maybe which probably we would discuss in further also, that it may be done in patients who have progressed where tissue remains a big challenge. Again, if the tissue is possible, probably I would still go for tissue. Having said that, there is a significant concordance now. And since IHC is available everywhere, including, I would say the most remotest of the places, almost all the patients probably would undergo MMR and maybe HER2 for all patients. And then the NGS probably I would offer to the patients, if possible, the RNA based. I rarely do fish these days, and that is my take on this. So KRAS, NRAS, BRAF are the common mutations. And of course, as I mentioned about the MMR has to be done. But I may not do POL and POLD for now. Rather, I rarely done it now in my practice.
Very nice. So Nikhil sir actually brought out all the way we clinically in oncology practice incorporate these biomarkers. Anup sir, your insights. Sir, you are muted. I can't hear you.
Previously we were only using RAS and BRAF, but at present we are at baseline itself we are sending NGS for limited panel along with MMR. And I usually go for a tissue-based NGS rather than liquid biopsy.
So tissue-based NGS seems to be like giving us taking a precedence over liquid testing, which is something which we use in later lines. So that's what both Nikhil and Anup told us. Now, Vamsi Krishna, would you want to just give us your inputs on these three questions? Any other biomarker, tissue liquid testing, and the type of testing?
Yeah, I think most of the times tissue will not be an issue, at least in this colon cancer. So I think still we are going with tissue-based testing, at least in the first line at baseline. And we are doing the broad-based panel testing for the reason that I think we'll have all the reports ready when the patient progresses eventually in CRC. And I think I'll agree with the panel on the testing methodology. I think NGS-based testing is what most of us are doing.
Excellent. So taking it forward now, Next slide. We all talk about left-sided metastatic CRC, and now we have data from CalGB 80405, FIRE3, Paradigm Peak, and Cairo also. And these pool data support the first-line use of anti-EGFRs in left-sided metastatic CRC. Above is the talks about the hazard ratio being 0.77. Now, and below, that's the OS data, and below is the objective response rate again with the odds ratio favoring anti-EGFR versus BEV with the odds ratio of 1.77. Next slide, and then we also have real-world evidence. Next slide, please. And this is a study called as the ACROSS study, which looked at close to 1,500 patients with left-sided metastatic CRC receiving first-line treatment in Spain over a period of 4 years, 5 years, and again showing the value of improvement in the median PFS and the median OS by using anti-EGFR plus chemotherapy in left-sided metastatic CRC. And so we were like, cetuximab-based combination regimens are right for left-sided metastatic CRC. Next slide. So Anant Pai, I would just like you to let me know, do you agree that anti-EGFR should be the preferred first-line treatment regimen for RAS wild type and BRAF wild type metastatic CRC? And if so, cetuximab versus panitumumab, your preference?
Thank you, Dattatreya sir, for the question. I think I do agree that anti-EGFR should be the preferred regimen when you incorporate in a left-sided RAS wild type, BRAF wild type metastatic CRC. The point that I want to make is that in case if they are not RAS wild type and BRAF wild type, or they are right-sided, my choice may change. But in a left-sided, probably I would still stick to anti-EGFR. Now coming to cetuximab versus panitumumab. I think efficacy-wise, I do not question each of them. But I think when it comes to toxicity, I have found that panitumumab is probably lesser toxic, easy manageable. Plus, I think so the dosing schedule helps us a lot. Unlike the initial conventional cetuximab dosing, which was weekly, then we have moved to bi-weekly. So for me, it's a choice. I would probably still stick on to cetuximab because I believe the data there is much stronger. We have had more experience with cetuximab. But compared to the side effect profile, I think panitumumab has lesser skin and hypersensitivity reactions.
Right. Dr. Vaishnavi would require your inputs on these two questions.
Yes, sir. So I agree. I think none of us have any different views about this. Anti-EGFR should with chemotherapy should be the choice in first line RAS wild and BRAF wild metastatic left-sided colon cancers. As far as cetuximab with panitumumab, our preference, all the efficacy data is the same. We still prefer cetuximab because of the longer data, and then we kind of started with cetuximab and haven't changed practice much. But then definitely if the rashes and the toxicity is the concern, some patients, few I have used panitumumab also. So.
Okay. But in my own practice, actually, my experience, of course, I agree with both of you that first line RAS wild type, BRAF wild type, mCRC, we will prefer anti-EGFR based combos. But I actually found cetuximab to be much better patient friendly when compared to panitumumab. But of course, we can have our own experiences. Next slide, please. And we then have some data which tells us, and this is like the bottom line, if you see, all RAS left side, right side metastatic CRC, if we use only bevacizumab-based combos, then the median OS comes to less than 24 months, and that was the ML180-147 study. Look at the RAS wild type left side mCRC using anti-VEGF based treatment first and reserving the anti-EGFR for second line and then other lines of treatment, we're able to somewhat reach the 30-month mark. But we're able to reach the 40-month mark, and this is the FIRE3 CalGB and SWOG data, where RAS wild type left side mCRC cetuximab-based chemotherapy first, then anti-VEGF based, and then third-line treatments and beyond, are able to touch or reach the 40-month mark. Next slide. And of course, we all know that various guidelines in our practice too, we look at continuing treatment until progression in patients who have unresectable metastatic CRC. And so we talk about continuing maintenance anti-EGFR based regimens. Next slide. And so there are various maintenance arms following the induction. Cetuximab monotherapy, cetuximab plus eflorapyrimidine, panitumumab plus fluoropyrimidine. And so we have all these options to choose based on all these trials and other trials too. Next slide. A critical review in oncology hematology looked at the maintenance strategy, and the conclusion was anti-EGFR plus fluoropyrimidine can be considered a valuable maintenance option in RAS wild type mCRC. EGFR monotherapy can be considered, these are left-sided tumors. So tumors left-sided, EGFR monotherapy, and overall RAS wild type metastatic CRC anti-EGFR plus fluoropyrimidine. Nikhil, I'll come back to you. So post-induction phase, how long do you continue anti-EGFR in the clinics?
So, provided the patient has I would say, partial response or a stable disease, even before this data came out, I think many of us probably would have continued these medications for a long time, just that probably we were not sure whether we were doing right. Especially when only the initial data was available with us, when you talk about FIRE3 and all. But in current practice, I would consider continuation of anti-EGFR therapy as much as possible. And as you already mentioned, the 5FU plus anti-EGFR probably seems to do better in this set of patients. And that probably remains practice for many of us, where we tend to add capecitabine and continue with the, I would say, minimum dose of capecitabine along with drug like cetuximab till the time patient progresses. So that is currently the practice what I follow.
Excellent. Vamsi Krishna, maintenance is what Nikhil is preferring, but would you think of choosing drug holidays from the antibodies like the stop and go approach, or you would also agree with Nikhil?
Yeah, stop and go approach, once the patient progresses, I think what we usually see the disease biology and then decide which way the patient goes. It's a primary metastatic CRC. Most of the times we don't usually give a drug holiday. Where I think probably the metastasis has come after some time post the adjuvant therapy, or when the disease biology is good, I think that's when you can prefer a drug holiday. Otherwise, I think continuing maintenance cetuximab for long, I think 2 weekly, I think 1 year to 2 years is very difficult. I think practically it's not possible, because most of the times the toxicity patients do request for a drug holiday, though I think evidence is for continuing.
Right. Dr. Anup, so both the panelists, Nikhil and Vamsi Krishna, have clearly told that their intention would be to continue maintenance. But then any clinical scenario where you think that you would not want to continue anti-EGFR in the maintenance space, any such clinical case where you in your practice might have decided that we might end up causing more harm than good by continuing maintenance EGFR, anti-EGFR?
Is that during induction phase, if the patient doesn't come across any difficulties with the tolerance issues with the anti-EGFR inhibitors, will continue with the maintenance until toxicity. But I don't think if you are experiencing a severe toxicity in the induction phase itself, then I may not be continuing anti-EGFR. Suppose, yeah. Otherwise, post-induction, there should not be
any reason
initiating anti-EGFR as a maintenance treatment in post-induction phase.
Excellent. Yeah, I think so. All three on the same page. So we have now understood the induction part and the maintenance part. Next slide. Now let's look at the first line, second line being defined. There are these guidelines which talk about multiple studies in third line that can be going back to a single agent anti-EGFR antibody in these patients who are KRAS and KRAS and BRAF wild type. There's data for irinotecan plus cetuximab. Of course, we all know about TAS102. We all use regorafenib. There's data about BEV and TAS102. And for HER2 positive disease, they talk about we just yesterday had had a meeting on tucatinib in Hyderabad, and then we also in the last slide did touch about trastuzumab plus ticatinib and trastuzumab plus deruxtecan as one of the treatment regimens for HER2 positive disease. So re-challenge with anti-EGFR antibodies in selected patients who maintain KRAS wild-type status can be an option. But there are some points we need to think before this anti-EGFR re-challenge. Next slide. So for instance, for anti-EGFR, you would want to look at the ctDNA analysis, previous response and interval, and is by chance a conversion surgery possible? Now that in third line would be something where it's a very limited disease. And for chemotherapy, of course, we want to look at the ECOG performance status, the previous adverse events, how FOLFIRI/FOLFOX went, and then the patient's willingness to think of an aggressive treatment option vis-a-vis the side effects. A systematic review and meta-analysis with a poster session coming up, next slide, talks about EGFR re-challenge versus an EGFR-free systemic therapy and showed that it can benefit metastatic CRC patients, particularly those with ctDNA RAS-RAF wild tumors at re-challenge. And then it significantly improves the PFS and the overall survival. And also it improved the objective response rates by around 10%. So this review basically did specify on looking at the ctDNA analysis as third line or beyond so that you can think of re-challenge provided they are still RAS-RAF wild type tumors. Next slide. One of the trials which gave an evidence of the efficacy of cetuximab re-challenge, though in a smaller patient population, was the cricket trial, a phase 2 trial design where it gave an objective response rate of 21%. Next, there was a data called as the CITRIC trial, which was again a phase 2 study, which looked at irinotecan plus cetuximab versus investigator's choice. And again, it showed that cetuximab irinotecan improved the PFS from 2.2 to 4.4 months, disease control rate from 44 to 74%. But there are limitations that these are small sample sizes and we require a larger population data set. And of course, we don't have the OS data also. Lastly, next slide. A Taiwanese study showed improved response for anti-EGFR re-challenge plus TAS102 when compared to an anti-VEGF plus TAS102. So we are ending up with cetuximab monotherapy as re-challenge or cetuximab plus irinotecan or even cetuximab plus TAS102. So with that brief overview, Anant Pai, could you let us know the next slide? Your preferred option in third line RAS wild type, left side metastatic CRC, and the factors you take into consideration before deciding the treatment regimen. Anant?
I think, yeah, I'm there. So the first thing would be the performance status and the organ dysfunctions I would look at. The second thing is the tolerance to what chemotherapy regimen was given and what were the toxicities, and whether toxicities persistent or have they been reversible. Like, for example, neuropathy, hand-foot syndrome, these would be very important toxicities that I would keep in mind, which would affect the quality of life of the patient. But definitely, yes, I've now started looking at liquid biopsy on a re-challenge for a patient who was initially wild type and to reconfirm. And for that matter, even those who were initially probably mutated, I would still do a re-challenge with a liquid biopsy just to see whether there's a change, which I believe can happen in some small population wherein initially it was mutated and then on a liquid biopsy it is found to be wild type. So my choice of preference would be based on the tolerance. Definitely, I would still stick to a doublet if the PS is extremely good, young patient looking at adding some more months to his life in the sense that he wants a survival benefit along with the good quality of life. But in an elderly population, I would try to limit it to a single agent or some kind of metronomic therapy with capecitabine and a targeted molecule like an anti-EGFR. Yes, cetuximab, I would still reconsider re-challenging looking at the data that you have just shown, sir. So PS, toxicity, and the baseline dysfunctions is what I would keep in mind and explain the benefits of the chemo.
Right. So I think very rightly you were able to point out that, and the third question also you answered that you would want to use liquid biopsy if possible and explain to the patient because then that will allow us to choose the anti-EGFR re-challenge in these scenarios. And then we always do look at the patient's clinical status, look at the ECOG performance status, the previous side effects, and that decides how to proceed further. So we have time till 8:30. Am I right, Shreyas?
Yes, sir.
Okay,
We have time till 8:30.
So next slide, please. There are some other novel strategies also, like for example, what about using KRAS G12C inhibition or anti-EGFR plus BRAF inhibition? And of course, we all know about the immune checkpoint blockades and then the antibody drug conjugates too. Next. So combination therapies can be based on the biomarker status. Next slide, please. For example, if it's KRAS mutated, we can think of incorporating the KRAS G12C drugs. If it's KRAS G12C, like sotorasib and adagrasib. Now, similarly, we talk about HER2 being amplified and then look at using the anti-HER2 amplification targeting uh, strategies. And if it's BRAF V600, then it can be encorafenib plus cetuximab. So that's come up in a big way. And so we know that, next slide, BRAF mutations are key oncogenic drivers in metastatic CRC, and that's like in 10% of patients, and we know this has a poor disease outcomes. But a study by name Breakwater, next slide, was able to look at encorafenib plus modified FOLFOX6, and this was like this has been considered practice changing because it met both the objective response rates and the PFS primary endpoints in first line BRAF mutant metastatic CRC. Next. So the first line standard of care now becomes encorafenib plus cetuximab plus mFOLFOX6 for BRAF V600E mutant metastatic CRC. And this could also be like telling us that we need to therefore look at KRAS and RAS, etc., and BRAF also, because then, though of course in India we don't have this molecule, but then it becomes and has become a next benchmark for these patients who are BRAF mutated. Next, but what next? So therefore, there's a study called as the CMARC trial looking at encorafenib plus cetuximab and pembrolizumab. So we are talking about no patients who are BRAF mutant, 10% of them, and then they're MSI high also. And so what happens? Shall we just think of using pembrolizumab or pembrolizumab plus cetuximab and encorafenib? So these trials looking at exploring, next slide, encorafenib-based regimens like the Southwest Oncology Group study also could possibly shed us the further way forward. But the beacon showed us the triplet and doublet therapy significantly improved the objective response rate and the overall survival rate. Next. Yeah. So I know on the previous slide, please. Yeah, I would like to now come to Dr. Vaishnavi. We know BRAF V600E has poor prognosis. Around 10% of patients are BRAF mutated, but that's what the data I showed you. In your clinical practice, what percentage of patients fall into the BRAF mutation category and how do you approach them? And then the next question is, if it's a BRAF mutation positive mCRC, though we know encorafenib in India is not available, but then does the data convince you, the breakwater, that encorafenib, cetuximab, modified FOLFOX for all these patients?
Sir, I think in our practice, almost the same, less than 10% could be BRAF mutant. And in these patients, and since they are subset with poor prognosis, and we know first hit is the best hit in any of the metastatic cancers. With that data, with Breakwater, I would definitely want to use, if the finances and availability and everything is satisfied with this data with encorafenib and cetuximab. Having said that, we have in our center used encorafenib for another patient who was not in the first line setting, but then in the third line, BRAF, the KRAS wild patient, in the third line, we found a BRAF mutation, and then we offered to the drug, and the patient son was also wanting to use it. So we have just 2 cycles we have completed, just giving 75 mg 2 tablets per day. So they're difficult to get the drug, but then in real world setting, we have to see how it goes. But yeah, first line setting, anything which can change the prognosis of this, bad prognostic subset, we should definitely use this with this drug. Yeah.
Absolutely. The data is so convincing that
Yes.
you would want to incorporate this for that patient who can afford that. And that's why it makes sense to, and that's what the guidelines also tell us, that like for that rare patient where you could get these rare mutations, we should not miss a chance, if they can afford, to give the best possible hit in the first instance. Next, let's come to immunotherapies. And we know that in MMR deficient or the MSI high metastatic CRC population, these are the current first line standard of care. Next slide, please, Shreyas. And that was the phase 3 Keynote 177 study. Okay. That was the phase 3 Keynote 177 study, which showed us a median OS of 77.5 months. Next slide. And then also we do talk about the Nivo-EP combination these days, and that was the Checkmate 8HW study, which again became one of the standard of care treatments for MSI high metastatic CRC. So this also has now become a first-line option for MSI high mCRC patients in the ESMO guidelines. Next slide. So we have this slide showing the 5-year follow-up in the ESMO 2023, and they show the clinical benefit of first-line Pembro for MSI high or MMR deficient mCRC, that these are durable responses. Next. And so I'll come to you, Nikhil. Like, I think we possibly see 3 to 5%. At least I think the incidence of MSI higher, now that we're doing it in almost every stage and every patient of rectal cancer, colon cancer who comes to us, the incidence seems to be less than 5%. But what do you see in your practice? Number 2, Pembro alone, Nivo alone, or Nivo plus EP, whichever the patients can afford. In those patients who can bring these molecules, what's your preferred option? I showed you the data. And then I did show you also about BRAF mutated and again MSI high, and then talking about encorafenib plus Pembro and cetuximab, and that trial is ongoing. But what would be your preference in the current scenario? Nikhil, if you could answer these 3.
Sure. So if you look at this DMMR data, I mean, I wish probably all of us probably would have this wishful thinking of having these patients coming to your office more often than not. Having said that, my experience again has been I'm almost like a handful of patients. So probably I would say that it's somewhere in the range of like 4 to 8% I can consider for DMMR colorectal cancers. That's what I would see from my patients. Coming to the treatments, now we had a data from Keynote 177, we had a data from Checkmate 8HW, 8HW. Now it's a big challenge to really do cross-trial comparison. If you look at the pembrolizumab data, there was a bit of a crossover, and there are reasons for that. But when you look at the Nivo EP data, with the PFS of almost touching 50 odd months, I think that, or to my mind, that remains my standard of care. If the patient can handle doublet over here, that is PD-1 plus CTLA both, that is probably my go-to regime over here, rather than having a single agent pembrolizumab. in unfit patient, probably I would still, or where the toxicity remains a challenge, I would consider pembrolizumab alone in those patients. And what about the patients who are MSI high and BRAF mutated? Thankfully, till now, I haven't come across a patient like that, because that's going to be a treatment dilemma for all of us. As you already had showed that there are studies which are going on in this space. Now, the challenge for such patients probably would be that these BRAF mutated patients might, or they do behave more, I would say, they are like hyper aggressive scores of their diseases. And that's where I probably would tend to use, if at all we have got encorafenib and everything available like a breakwater, I would, in the initial part, would consider for encorafenib cytolytic EC chemotherapy, EC Polfox, you can say, and keep maybe the immunotherapy for a second option. Because if you don't get a response in the initial part for immunotherapy, then I believe the patient might be in trouble.
Absolutely. Anup, would you like to add some comments? I think Nikhil pointed so very well that, say, for instance, single agent Nivo, the PFS is 40 months. The Nivo EP is like 55 months or 54 months. So Nivo EP seems to be really making an impact on the MSI high tumors. But your inputs and thoughts on single agent Pembro or Nivo versus Nivo EP?
Yeah, based upon the data, I will definitely go for combination Nivo EP. But my experience are only in pembrolizumab alone.
Yes.
Yeah.
Me too. Yeah. Okay. So, but let's proceed forward. It's almost 8:30. So patients with KRAS, next slide. KRAS G12C, now switching gears to KRAS G12C mutant CRC. These patients have worse prognosis than those patients who don't have the, next slide, please, Shreyas. So you could have KRAS G12C versus KRAS non-G12C mutant CRC. Approximately 1/5 or 20% of patients are KRAS G12C. And the reason I brought this out here is because we have drugs which can target KRAS G12C, which is sotorasib and adagrasib. So we have a trial called as Crystal 1, next slide, which talks about adagrasib plus cetuximab to show some meaningful efficacy, PFS of 6.9 months and median OS of 16 months. Next slide. And then we have, if that was a phase 2 study, then this is a phase 3 trial called as the CodeBreak 300, which again supports the role of anti-EGFR and KRAS G12C inhibitors in second line or beyond for these metastatic CRC patients. Next slide. And so, Vamsi Krishna, first of all, are we tuned to look at KRAS G12C, or we just say it's a mutant KRAS? And if so, then KRAS G12C in your practice. And then for KRAS G12C mutant population, with what the few slides I showed you about Crystal 1 and CodeBreak 300, what would you want to do?
Yeah, I think KRAS mutation, we are checking for the G12C. With this NGS testing, we are getting the G12C mutation. And the percentage wise, I think definitely I'll say it's more than the MSI deficient MMR patients. So this is population of patient is high, and the prognosis for these patients is very poor because they at times tend to change case very fast. And in the clinical practice, I think in the initial first line setting, we are still going with the standard practice of chemotherapy only. And data wise, it's good. And I think in the second line, I think we do have data. Have tried using anti-EGFR with sotorasib in few patients where we imported the drug incident, but we get good response rates with this combination, especially in the KRAS G12C.
Excellent. Yeah. I think you nicely summed it up that we should now also try to look it up as the type of the KRAS mutation, because we can definitely source some of these drugs for our patients from abroad if required. Next. So coming to the last two sections of my moderation today, one is to look at the anti-RK fusions, and the second is to look at the HER2 amplifications. Next slide. And so we know that we have these TRK inhibitors, like larotrectinib and entrectinib, and they can be used for third-line treatment or beyond for anti-RK fusion positive metastatic CRC. Uh, Dr. Vaishnavi, could you just let me know, have you ever seen patients of anti-RK fusion positive metastatic CRC? And otherwise, also in other malignancies too, have you been able to use laro or entrectinib?
No, sir, I've not been that lucky. I've been in sarcomas, at least we all want to get lucky, just find a patient with NTRK fusion. But till now, I've never found a patient with NTRK fusion, not used these drugs yet, sir.
Right. Yeah, same with me as well.
Yeah.
The last slide. Thank you so much, madam. Finally, we'll come to Anant Pai now to close this session. And so I did speak about the HER2 amplified metastatic CRC. And so I listed there 3 treatment options based on the trials. What would you prefer, Anant Pai, like if you get a HER2 amplified metastatic CRC and now it's second line and beyond, trastuzumab, lapatinib, trastuzumab, pertuzumab, PDXD, and what about the Mountaineer, tucatinib plus trans, because now we do have tuca also available for us. Anant?
I have used trastuzumab, pertuzumab for a patient, I think in the 4th or 5th line there. But didn't have much promising results with that, probably because it was too late in the day as well, 4th or 5th line. But I think I haven't used deruxtecan yet in a CRC. Trastuzumab plus lapatinib, yes, for one patient probably, as a third line, but the lapatinib was not tolerable because the patient already had a bad HFS with the previous 2 regimens. So, but I think it is interesting that we are looking at these targets as well. And like Dr. Vaishnavi was saying, I have found 2 interact positive patients, but hardly had the opportunity to use them. So there was joy on one side that you found the interact mutation, but it didn't turn out joyful enough because you could not use the molecule. But trastuzumab, pertuzumab, yes, but I'm not very happy with the results that I've seen. But it's only a handful of patients, sir.
Right. Thank you so much, all the panelists, for all those inputs given by all of you. But it tells us, and that's what all of them alluded to, that looking for biomarkers has now become the current standard of practice. And if we can get hold of the right drugs for that right patient, and if they can afford that, then it does translate to a change in the outcomes and especially impacting survival results. So with that, Shekhar Patil sir, I would like to hand over the session back to you.
Yeah.
Thank you so much.
Yeah. Thank you, Dr. Tatras. It was a wonderful discussion. I think you have covered almost all aspects of metastatic colorectal cancer. You made it so simplified. And just as I would like to conclude by giving few points which I feel may be relevant. Basically, one discussion we should have is more of a liver-limited disease, where in a metastatic colorectal cancer, where cetuximab has made a big impact because now we are able to get a deeper and a faster response and make it more resectable. I think that is one. And you were discussing about the microsatellite instability patient, how to decide between the dual versus the single agents, particularly whether it is Nuo or Pembro. Always, if the volume of the disease is too high, I think dual may be a good option. Only in a small subset of patients who are very frail and the volume of the disease is low, one can look into nivolumab or pembrolizumab as a single agent. That is what I felt with the discussions what you people are having it. The third is about the HER2 new. I think we should discuss about the point of not going for cetuximab if somebody has got a HER2 new mutation. So that's only that will become a baseline marker to be checked when we are doing with the NRAS, KRAS, HER2 will automatically come. So that is another thing we always look into it. And later part, if we can use in the third line with generally we know the good data is on the tucatinib with trastuzumab and capecitabine. I think the data appears to be quite promising. Other than that, will be the trastuzumab deruxtecan is another thing. And uh, going to the BRAF mutation, I think the latest on the combination of chemotherapy with BRAF inhibitors, that breakwater study is really a great study. I think that has made the way the survival things have improved in that group of people who received it is really, I think that will become a first line treatment. I was always thinking that when corfinib is not available, whether we can replace with this dabrafenib or trametinib, whichever we are having with the things. But it may be wrong, basically, because we don't have any studies available in that one. That is, these are the few things which I felt I should share with you. And really, it was wonderful discussion. And thank you, Dr. Tatri sir, for the nice. Thank you very much. Thank you. Thank you, sir. Thank you.
Yes, thank you so much, sir. Thank you for concluding the session in the best possible way. And it was a pleasure listening to the discussions, to the sessions today. I think we are just 5 minutes late ahead of the schedule. I would just like to take an opportunity to thank our esteemed faculty. So we are grateful to all of you for sharing your experiences, particularly when we are moving into the biomarker-driven approach in metastatic colorectal cancer. And the discussion was quite interesting, ranged from the first line to the third line setting, as well as some novel biomarkers and their treatments. So with that, I would just like to conclude the session. Thank you all for joining. It was a pleasure listening to all of you, and we have collected a lot of insights. And just one thing, that with our new NGS initiative, which the Merck has launched, I hope that many of the patients will be benefited going ahead and will be able to use this NGS initiative. So take care, everyone. Wish you all a restful evening and a great day ahead. So good night. Thank you, everyone.
Thank you.